General principles of management. Establish the diagnosis, usually clinical and by bedside tests. Auspitz sign, GUTTATE test. If in doubt, refer to higher center for evaluation and skin biopsy. Assess for psoriatic arthritis and metabolic syndrome, obesity, dyslipidemia, diabetes, hypertension. Counsel about variable natural course of disease and expected treatment outcome and lifestyle modifications, including weight reduction, avoidance of smoking and alcohol. Assess for requirement of systemic treatment in addition to topical treatment. Advise regular use of emollients and moisturizers. Antihistamines if pruritic. Avoid methotrexate and cyclosporin A in children scheduled for live vaccines. Rule out tuberculosis, HIV, hepatitis B and C infections before systemic immunosuppressive treatment. Pregnancy test prior to systemic therapy. Acritrin avoided in childbearing age group. Systemic steroids should not be given for the treatment of psoriasis except for generalized pustular psoriasis of pregnancy. If first-line treatment options fail or are contraindicated, refer to tertiary care center for combination. Baseline investigations to be carried out. These principles should be used only as a general guide to choose a treatment. Final decision should be made on case-to-case basis. Treatment overview. Topical therapy less than 5% of body surface area. Moisturizers like white paraffin, topical corticosteroids, tacrolimus ointment, tazarotene, calcipotriol, coal tar, dithranol, salicylic acid combinations. Phototherapy more than 5% of body surface area. PALMOPLANTAR psoriasis, narrow band UVB, targeted phototherapy, topical or systemic PUVA or surveillance with sunlight, PUVA-SOL. Systemic therapy, more than 5% of BSA, severe recalcitrant disease, palmoplantar psoriasis, arthritis. Methotrexate, cyclosporin A, retinoids, isotretinoin may be preferred in adolescent girls, acitretin, oral antibiotics, guttate psoriasis, novel small molecules, resistant cases, biologics. Variants of psoriasis: plague psoriasis, guttate psoriasis, palmoplantar psoriasis, erythrodermic psoriasis, pustular psoriasis. Plague psoriasis: erythematous plaques with silvery white scales. They are divided into two: limited plague psoriasis, less than 5%, and generalized plague psoriasis. Limited plague psoriasis, primary and secondary level, face and flexures, 1% hydrocortisone, low potency steroid cream, OD for 2 weeks, trunk and extremities, betamethasone cream or any other potent steroid, preferably with salicylic acid, 3 to 6%, OD for 2 to 4 weeks. Other topical treatment as listed in treatment overview. Tertiary level, continue with topical treatment. If patient does not respond in 6 to 8 weeks, try alternate topical agents and or systemic therapy or NB, UVB, PUVA or PUVA-SOL. Generalized plague psoriasis, refer to general principles of management, preferably to be managed at higher center. Systemic treatment, refer to treatment overview. If these fail or are contraindicated, refer to tertiary level for combination or rotational therapy, novel, small molecules or biologicals. Continue emollients, avoid irritants and prolonged use of topical steroids. Scalp tar based shampoo and topical steroids with or without salicylic acid lotions. Guttate psoriasis. Clinical features: shows of numerous erythematous plaque papules less than 1 centimeter on the trunk and extremities. seen more commonly in younger patients. Treatment. Refer to general principles of management. Primary health center level, antibiotics for streptococcal infections. Secondary level, same as primary level with soral and ultraviolet. Tertiary level, same as primary level care with narrowband UVB. In refractory cases, consider systemic treatments including novel small molecules. Palmoplantar psoriasis, chronic erythematous, well-defined plaques symmetrically on palms and soles and occasionally nail involvement, to be differentiated from palmoplantar eczema. Refer to general principles of management. Primary health center, topical petrolate at least twice daily. Add antibiotics if signs of infection. Potent steroid salicylic acid combination. Refer to higher center if not responding in 6 to 8 weeks. Secondary care hospital and tertiary care hospital. In addition to those treatment prescribed at primary care, tar-based applications or steroid salicylic acid with occlusion if very thick plaques for 2 to 4 weeks. Phototherapy, hand and foot NV, UVB, PUA socks. Systemic therapy, refer to treatment overview. Erythrodermic psoriasis. Clinical features, generalized erythema and scaling involving more than 90% of the BSA, triggered by withdrawal of systemic corticosteroids, potent topical steroids, or HIV infection. Common differential diagnosis: dermatitis, drug reactions, pityriasis rubra pilaris, idiopathic erythroderma. General management at primary care: stabilize patient and treat secondary infection, maintain temperature, fluid and electrolyte balance, admit if febrile and unstable vitals, high protein diet, lab investigations, complete hemogram, liver and kidney function test. Refer to higher center for specific management. Specific management: skin biopsy if in doubt, methotrexate or cyclosporin A, maintenance acitretin, NBUVB, PUVA. If patient fails to respond, consider biologics. Pustular psoriasis, clinical features: crops of localized or generalized sterile pustules and lake of pus with surrounding erythema, often associated with fever. In pregnancy, presents as impetigo herpetiformis, may lead to intrauterine growth retardation or stillbirth. General management at primary care: stabilize patient and treat secondary infection, maintain temperature and fluid and electrolyte balance, admit if febrile and unstable vitals, high protein diet. Lab investigations include complete hemogram, liver and kidney function test. Refer to higher center for specific management. Specific management: assess patient, take drug history, particularly beta-lactams, macrolides, calcium channel blockers, to rule out acute generalized erythematous pustulosis. Generalized pustular psoriasis: admit the patient and follow general measures as for psoriatic erythroderma. In addition to blood tests as listed previously, serum calcium, patients may have hypocalcemia, should also be estimated. Acitretin, methotrexate and cyclosporin. Psoriasis is completely treatable but has a chronic course.